Next, we have Dr. Claire Snyder, Associate Professor of Medicine at Johns Hopkins Medical Institutions, and she's going to present the views of a PCORI grantee using patient-reported outcomes data to improve patient and clinician understanding and use. Claire.
Thank you. It's my turn to fight with the computer, so we'll see how that goes. I want to thank Kay and the meeting organizers for inviting me to be here today to talk to y'all about our experience in our funded PCORI project of stakeholder engagement. So the title of our PCORI contract is Presenting Patient-Reported Outcomes Data to Patients and Clinicians to Promote Understanding and Use. I'm actually going to talk only one slide about the actual topic of our project and really focus on the role of stakeholders and the way that we've engaged stakeholders in it. Okay, everyone? Hope. Yay! Hard part's over now. So just to orient people to what I mean when I say a patient-reported outcome. As we know in healthcare, there are a variety of outcomes, things like tumor size and cancer, clinician-reported ratings of functioning, caregiver-reported measures. What we focus on in our project is patient-reported measures, and these include a wide variety of topics, things including global impression, functional status, symptoms, quality of life, treatment satisfaction. And to measure these outcomes, there are actually a vast array of questionnaires that have been developed to measure all the different outcomes. There are thousands of questionnaires out there. But unfortunately, there are no standards in the way those questionnaires are scored, scaled, or in the way that the data are presented with the results. So on some questionnaires, higher scores mean better function and well-being. And on other questionnaires, higher scores are worse. And actually, on some questionnaires, whether higher is better or worse depends on the specific topic within the measure. Only us researchers could come up with this. Another variation is that some measures norm scores to the general population. So things like a score 50 means that's the way the normal US population is, but other scores, 100 is best possible. So there's differences in scaling. And a final area of variation, and the one that we're trying to address, is differences in the way that the data are presented. So sometimes we see line graphs, sometimes we see bar charts. The FDA has come up with and recommended an extremely complex depiction of score distributions. And what we hear from patients and what we hear from clinicians in the work that we've been doing is that this variability poses a barrier to their understanding what the data mean, and if they can't understand what they mean, then they can't use them in patient care. So that's the topic that we've decided to tackle with our project. So now that you understand what the project is, the next question is, who are the stakeholders? Well, obviously patients and caregivers are stakeholders in this. But clinicians are also stakeholders in this. Clinicians also have to try and understand the data, and clinicians play an important role in discussing and translating that information to patients and clinicians. And finally, patient-reported outcome researchers are important stakeholders in this. After all, we're the ones who develop the questionnaires, we're the ones who recommend how they're used in different studies, and so getting buy-in from the pro-researchers is equally important. So when we first decided to write our PCORI grant and we had our idea in mind, our first step was to make sure that all stakeholders were involved in our investigative team. So meet Alyssa Bantug. Alyssa is a breast cancer survivor and patient advocate. She runs our breast cancer survivorship communication and education programs at Johns Hopkins. She is a co-investigator on our project. Meet Michael Brundage. Michael Brundage is co-principal investigator with me on this project. He is a radiation oncologist, so he provides the clinical perspective. And then Michael and I are both PRO researchers. So what we did early on was ensure that all the stakeholders were members of our core investigative team. This is actually our entire team plus one co-investigator who brought methodologic expertise. But what we tried to ask ourselves throughout the process is, how can we be broader? So I've already said that all stakeholders are on the investigative team, but to be broader, we have a 9-member stakeholder advisory board with additional perspectives and representation of the stakeholders. Additionally, for our data collection, while it would be feasible to collect all the data we needed only from the Johns Hopkins Cancer Center, we've actually incorporated a consortium of hospitals affiliated with Johns Hopkins that include both academic and community practices, as well as rural and urban settings, so that we get a broader perspective. And finally, for the last part of our project, we're going to be doing internet-based surveys of national samples of pro-researchers, of clinicians, and of patients. So we've tried to be as broad as possible. How can they contribute? Well, we've incorporated them throughout the continuum of the research project. As I mentioned, the whole project itself came from previous research Michael and I had done, where we had patients and clinicians telling us, we think patient-reported outcomes are important, but we don't understand what they mean, and we need a standard way to look at the data. So for study design, all stakeholders included on investigative team with additional stakeholder representation through the stakeholder advisory board. This helped us a year ago when we were designing our project. For study conduct, as I mentioned, we're not just trying to get representation from Johns Hopkins Cancer Center, but from the region and national samples. And for our intervention development phase of our project, we actually will have stakeholders who will be in work groups. They won't be study subjects. They will be actually developing the interventions with us. And then finally, we were very strategic in selecting our stakeholders so that everyone wore more than one hat, so that everyone was not only in a position to contribute to the conduct of the study, but was in a position to help us with implementation and dissemination. So these are the 9 members of our stakeholder advisory board, and I'm just going to highlight how a few of them wear multiple hats. Ellen Stovall is a patient advocate. She was a founder and continues to be involved in the National Coalition for Cancer Survivorship. She can help link us with patient advocate groups for conducting our patient surveys. And her advocacy expertise will be extremely important to us for implementation and dissemination. Patty Gans is an MD. She's an oncologist. She provides a clinical perspective, but she's also been involved in PRO research and has developed a survey, so she can provide that perspective as well. And she's involved in several of the cancer cooperative groups. So she's a connection for us with a range of oncologists across the country. And then Bryce Reeve is a PRO researcher. He's been involved in developing the PROMISE system through the NIH. He can help us put our survey out to the International Society for Quality of Life Research, as well as have ISOQOL, he's the ISOQOL president, for example, endorse the standards that we've produced. So to sum up, the key lessons are: determine who the stakeholders are early on, include stakeholders in every step of the process, be as broad as possible, and select stakeholders who can facilitate both study conduct and effective dissemination. And I just wanted to conclude by acknowledging our project team. Thank you.